So in the last lectures, we talked about how epidemiologists do research and the different indices, dental indices that they use to collect data. Now I want to switch our focus into the actual epidemiology of oral diseases. So epidemiologists have employed the different research techniques and they've published this data out there about the different prevalence and incidence rates of different oral diseases. And you'll see different factors and different patterns of who in the community is more likely to have certain oral diseases compared to other people in the community. So this is our lecture outline. We're going to talk about oral health disparities overview, and then we're going to get into the nitty-gritty of the different epidemiologies of the different oral diseases. And you can see we're going to be talking about the epidemiology of caries in video 1. And then in video 2, we're going to talk about periodontal disease and edentulosome. And then in video 3, we're going to talk about oral cancer and fluorosis and oral health in Kentucky, and then wrap things up for this particular lecture. So in 2000, and I believe I've mentioned this in class before, but in 2000, we had the first ever Surgeon General's report on oral health, and it was released in 2000. And what it found was that it had 3 key findings. And what it found was that oral health is essential to the general health of all Americans. So, I mean, that seems very commonsensical to us right now. But it was kind of groundbreaking at that point because people really kind of thought of the mouth and the oral cavity as something completely separate compared to the rest of your body. But the Surgeon General really wanted to emphasize that the oral health was essential to our overall general systemic health, and it can be achieved by all Americans. But not all Americans are achieving the same degree of oral health. So some Americans are having great oral health and other Americans are not. And they also found that substantial oral health disparities existed among different subgroups in the U.S. population. And I think a lot of times when we hear the term disparities, we often interpret that to mean racial or ethnic disparities. And that's, while there are some racial and ethnic disparities, there's also a lot of other dimensions of disparities that exist in the U.S. and specifically within our health. If a health outcome is seen to be greater or lesser between populations, there's a disparity there. So some disparities can include people of different races or ethnicities, obviously, but people of different sex or sexual orientations, ages, different disability levels, different socioeconomic statuses, as well as geographic location. And all of those things contribute to an individual's ability to achieve good health and good oral health in particular. So this is just a definition from HRSA, the Health Resources and Service Administration, published on what is health disparities. So when we're talking about oral health disparities, we also need to think about oral health indicators, and these are measurable characteristics. So we might be utilizing some of our dental indices to figure out the extent of dental caries or gingivitis or oral cancer or periodontitis, whatever oral disease that we're really interested in. We might be utilizing that during our research to be able to collect the data to describe the health of that population within that community. But it also includes other determinants of health, which includes oral health behaviors, so individual behaviors. It could also talk about risk factors, which we talked about in a previous lecture. It could even be something greater, on a more neighborhood type of level, in which people are in physical environments and how that impacts people's health overall, and along with socioeconomic statuses. Also included is access to care, which we'll talk about access to care in the very next lecture when we're talking about utilizing dental services. But that is an oral health indicator as well. In 2017, the Louisville Metro Public Health Department published the health equity report for the Louisville metro area, and I thought that they did a really nice job in terms of illustrating how different aspects are interconnected, and I really in particular liked this particular picture from their report. And basically, they are going from very macro level institutions to how very macro decisions and institutions will impact an individual's overall health. So what they're saying is that the systems of power are very much rooted in our very being. And in this particular illustration or metaphor, it's in the soil. We'll find systems of power like racism and sexism and any of those other isms that are out there. And these systems of power actually impact how people experience the root causes of their health and health equity. So things like racism and sexism and ageism will impact a person's likelihood of staying in a certain neighborhood, or educational attainment, or the types of jobs that they'll be able to get later on in life. So all of those types of things shape the root causes, which are housing differences, access to care differences, what's in our neighborhood, are there good healthy grocery stores in our neighborhood. All of those will impact our overall health income, which are like the branches of the tree. So the individual branches are the individual people within the community, and those health outcomes really fall on that range of health. So we talked at the very beginning of the semester that health is not a dichotomous thing where you're either sick or you're not. There's actually a continuum to health, and someone falls between super healthy and super sick. So they fall between those two ends. So things like asthma and heart disease and oral health are actually outcomes that are caused by these root causes. So think about in oral health education, we talked about the community theories, the community level theories, and one of the theories in particular talked about the aspect of the root causes, and you can't just slap a band-aid over something and then expect totally different outcomes later on. You really have to fix the root causes to be able to ultimately change the overall health of a community. So this is what, like I said, in 2017, the Louisville Metro Public Health Department published the Health Equity Report, and this was part of their report. So let's talk about the epidemiology of caries in particular. So what we know through the data is that the incidence of cumulative caries has been declining for the past few decades. Don't get me wrong, it's still very widespread in the adult population, but at least we're seeing a drop in the incidence of cumulative caries. Uh, Approximately about 94% of the adults in the U.S. have showed evidence of past or present coronal caries. So it's still really widespread. What we've seen a decline in mostly is a decline in smooth surface decay. So we're still seeing pits and fissures still being decayed, but we're not seeing as much of that smooth surface decay overall. And this is likely attributed to all the fluoride programs that we've had out in the community, whether it be water fluoridation or a fluoride varnish program. We also see that there's some trends in terms of where we're finding decay in kiddos' permanent teeth. So think about dental anatomy and where a kid is most likely to be missing and develop decay in those areas. So most likely place that we're going to see decay in kiddos' permanent teeth are the buccal pits of the mandibular molars, so 19 and 30, and the pits and fissures on occlusal surfaces. So we're seeing occlusal decay, and then that buccal pit decay is where we're most often seeing it in kids that have developed their permanent teeth and erupted their permanent teeth. So obviously the first and second molars are the most frequently affected for decay. We also know that the proportion of the population that has never had a cavity is also increasing, which is awesome. The overall trend is that we're seeing less severe caries. So we're seeing less bombed out teeth. We're also seeing fewer carious lesions in the anterior teeth. And we're also seeing that people are actually repairing their teeth and doing restorations. And we're not seeing as many teeth that are lost due to cavities. When we're talking about kids in particular, to correspond with the data on the previous slide, we're seeing that there is an increase of caries-free children, which would make sense. If we're seeing more adults that have never had a cavity, it would make sense that we're also seeing more kids that have never had a cavity as well. And we're also, this is a very exciting trend. We're also seeing a decrease in untreated decay in 2 to 5 year olds. So that's really a good thing that that young population, while they still may have decay, at least they're getting it treated and getting the toddler and preschooler out of active decay. Obviously, there's some racial and ethnic disparities amongst elementary school kids and some preschoolers. So we typically see more cavities, more carious lesions in Mexican American and non-Hispanic Black children. While these statistics are encouraging in terms of having an increase of caries-free children and a decrease in untreated decay, we still know that dental caries is still the most prevalent unmet health need of the U.S. children. We know that it's the most common chronic childhood disease. It's 5 times more common than asthma, 7 times more common than hay fever, which, you know, those are pretty prevalent within that child population. So that's very significant. And because of the great amount of dental caries in this population, it ultimately impacts their education. Because if you have a kid that has decay and it's a more advanced decayed lesion, they're not really going to be concentrating on their schoolwork and being able to, master some of the simple things that you have to get under your belt before you go into more advanced concepts. And we see a loss of educational attainment in terms of school hours. They're not coming to school, but we're also seeing that these kids are getting a little bit behind in their educational attainment compared to their peers. In Kentucky, we know that about a third of the Kentucky kids have untreated decay, unfortunately, and about 2/3 have had a caries experience, meaning that they've had untreated decay or they've had decay and they've had it treated. So remember, cumulative caries experience includes both treated and untreated caries. The not so great thing we could do a lot better in Kentucky is the prevalence of silence. Only about 29% of third graders had silence. So remember, we're seeing decay in those pits and fissures of the occlusal surfaces. So hopefully if we could increase our silent programs that are out there, then hopefully we could see a decrease in this percentage of decay that's out there. Ironically, the two states that had the lowest untreated decay rates are New Hampshire and Kansas. And Kansas, I know for a fact, has a very aggressive public health service to children. They have a lot of public health hygienists that actually go and do fluoride and sealant programs, and they go to every single school in the state of Kansas. So they have a very advanced program to do all that screening and to do the sealant and fluoride programs. So the pattern of caries, and this is one of the statistics that I want you to know. All the other ones, just know the general trends, but I do want you to know the specific statistic. 75% of the caries occur in 25% of the population, and that is crazy when you think about it. So if you had 100 people and you're looking at 100 people, that would mean that 25% would have 3/4 of the caries. So think about a dental class, and I know we have about 120 dental students in each class, but let's pretend that we have 100 dental students in each class. 25 of those people would have the good majority of carious lesions compared to their classmates. And this, and we'll see it here in a second, these inequalities actually are rooted in socioeconomic statuses, in race and ethnicity, as well as educational attainment. So in terms of coronal caries, when we're talking about race and ethnicity, we know that the total untreated decay rate is about a quarter of the population, so about 26% of the population. We do know that minority, racial, and ethnic groups have the highest amount of untreated decay. And actually, when you break it down, it's actually blacks and Hispanics have the highest rates of untreated decay in the adult population. So they define adult population ages 20 to 64. Native Americans actually also have a really high decay rate, but we don't have comparable data to be able to include them into this pie chart. Some data shows that about 90% of the Native American teenage population have had caries. So that's pretty significant in that particular population. The CDC has noted that people that are ages 35 to 44 of the Black and Hispanic populations have had 2 times the amount of active decay than non-Hispanic whites. So that's also significant. Non-Hispanic whites have lower decay rates, and they also, when they do have decay, they tend to get it treated. So they have the least amount of untreated decay. What's really interesting, though, when you're looking at the DMFS and the DMFT scores, whites actually have the highest scores. Why do you think that? It's because of the fact that they're looking at not only decayed, but they're looking at the missing and filled categories. So you can't just go on the DMF score, the DMFS or the DMFT total score. You really have to break down each one of those categories to see where people fall. And if you broke down the DMF for different racial and ethnic groups, you would see that whites actually had a higher amount of the fillings and the missing compared to the D for the decay. And that's why their cumulative caries experience, that number is higher. In terms of income, people that are poor, people that have lower income have more decay, and it's more likely to be untreated. So they're more likely to have active decay, more likely to see it progress into bigger issues in terms of caries, like more bombed out teeth and whatnot. That ultimately impacts their activities. So they have a lot more restricted activity days, meaning that they're calling into work and they're not as productive at work whenever they're there because they can't really concentrate on the work whenever they have a toothache, or they leave early, those type of things. So not only work, but that also impacts education. So if they're pursuing education, or if they're in high school, that also leads to those more restricted activity days as well, for people that are pursuing education. In terms of age, we know that the untreated decay prevalence is similar for 20 to 64-year-olds. The range is about a quarter of the population has untreated decay. It is slightly lower for those elderly people, 65 years and plus, but it's fairly similar. Caries experience, people that are 35 years or older is higher compared to younger adults. So people that are in late teens or in their 20s tend to have a lower caries experience. And that makes sense because people that are older have more exposure during their lifetime. So they are more susceptible to caries for a greater amount of time. Other factors, education definitely impacts coronal caries. Adults that are aged 35 to 45 years old with less than a high school education experience. Untreated tooth decay nearly 3 times that of adults with at least some college education. So that's really significant too. People that have had less than a high school education, so they dropped out of high school, have 3 times the amount of untreated decay compared to people that are in college or have attained higher degrees. In terms of gender, we also know that females have a higher DMFS score than males. Again, you have to break down and look at the D and the M's and the F's. And when you look at those different components of the DMFS, you would see that females actually have lower untreated decay. So they have higher scores in the missing and the filling compared to males. Why is this? Not really 100% sure, but we do know that women have earlier eruptions typically. They tend to erupt their permanent teeth just slightly before males, so that could make them a little bit more susceptible in terms of having the tooth erupted into the oral cavity at a longer time compared to males. And they also tend to have more frequent dental visits, especially for more preventive types of things than males. Diet also, definitely impacts coronal caries. You all had a huge nutrition unit in theory, as well as health behaviors, brushing and flossing, how they take care of their oral health. People that have had radiation experience xerostomia really severely, and that impacts coronal caries. And then, of course, tobacco usage impacts coronal caries as well. We're really concerned about the sugar and spit tobacco in particular when we're talking about tobacco. Early childhood caries is another component of caries epidemiology. The American Academy of Pediatric Dentistry changed the definition of early childhood caries, and basically they made it a lot more encompassing. It used to be, and when I was in school, early childhood caries was just a carious lesion on the anterior maxillary teeth, for the primary teeth for kids. But the AAPD actually expanded it and said that it could be any tooth that is decayed, missing, or filled. So any primary tooth that's decayed, missing, or filled in a child that's 71 months of age or younger. We know that about a quarter of the 2 to 5 year old population have early childhood caries, and it has a racial and ethnic component to it, and it's more prevalent amongst the Hispanic and African American populations, and it's more prevalent in lower socioeconomic statuses. So when you're looking at early childhood caries, SCS, lower SCS, is the most powerful predictor of whether a child is going to get carious lesions or not. This is a graph from the NHANES survey. The NHANES survey is like the BRFSS that I previously have talked to you all about. But it's another national survey. It's a cross-sectional survey. And they do interviews, and they collect data with doing screenings, dental screenings, and other types of health screenings. So it's really an inclusive survey that is very well known in terms of getting data. So this is a chart from the NHANES, and you can kind of compare the different groups of people in terms of their dental caries experience as well as their untreated dental caries. And then finally, we need to talk about root caries. Root caries occurs in about a quarter of the adult population. And you have to have recession, obviously, to be able to have root caries, because you have to have the exposure of the root. And in healthy dentition, you know that our gingiva, covers our root surfaces and goes up past the CEJ slightly. So you have to actually have a little bit of recession to be able to have root caries. And recession, obviously, increases the chances of getting recession increases as we age. So root caries, the prevalent, also increases as we age. And if you're breaking down the data, those people that are over 75 years or older, about 50% of that population has had root caries. It's more prevalent in males than females. Really don't have an explanation for that as to why it's more prevalent in males than females, but it is. And then there's a racial and ethnic component to it, and African Americans show slightly higher prevalence than white Americans. And again, minorities, racial and ethnic minorities, have more of the untreated disease compared to whites. Other factors when we're talking about root caries, socioeconomic status. So, poor people are more likely to have root caries and more likely to have untreated decay in the root surfaces. We talked about gingival recession. Something that a lot of people don't think about is that if a person has had past coronal caries and whether they've had it treated or not treated, it doesn't matter. Um, it's significant. If you've had those caries in the coronal part of the tooth, then you're setting yourself up to being more likely and more at risk for caries later on if you have the gingival recession. You have that bacteria that's already established within your mouth in colonies, so it's just ready and waiting to be reactivated in the lower pH and having the carbs and the sugars introduced into the oral cavity. Of course, oral hygiene impacts root caries, especially as we age. We might not have as much dexterity to be able to really kind of get those root surfaces cleaned. Multiple medications cause xerostomia. So the xerostomia actually, sets the mouth up for it, makes it ripe for carious lesions along with radiation treatment. And then tobacco use, obviously, spit tobacco specifically will impact root caries and increase the likelihood of root caries. Something I didn't think of about diet is that as people age, they tend to have an increased sugar intake. So they kind of crave a little bit more of the sweeter types of foods. And that's because our sense of taste diminishes as we age, and our eating habits change with age as well. And we'll talk a lot about that during special needs when we have our geriatric unit. But all of those things combined heightens a person's risk for root caries. So that is the epidemiology of caries. In the next video, we're going to talk about periodontal disease and edentulosum rates.